So good afternoon, everybody. I am Dr. Aman Sharma, consultant with the Quality and Patient Safety Division of National Health Systems Resource Center. I welcome you all to the third series of the Standard Treatment Guidelines. With me, I have Dr. Chinmay Swen, Senior Consultant in the Quality and Patient Safety Division, NHSRC. I also have Dr. Sangeeta Sharma ma'am, who is the head of the DSPRUD, that is the Delhi Society for Promotion of Rational Use of Drugs. And we also have our esteemed speaker for the today's session, Dr. Anup R. Warrier, who will be taking, who is the senior consultant in the infectious disease section of the Aster Medicity, currently placed at Kochi. We will also have our other speaker, as told by Sangeeta ma'am, Dr. A.P. Dubey, who is the ex-director, HOD, and professor of the pediatric department in the Maulana Azad Medical College of New Delhi. He'll be joining us soon for the session. So to begin with, I would like to invite Dr. Chinmay Swen for the opening remarks.
Thank you, Aman. Namaskar. I am Chinmay from Quality and Patient Safety Division. I welcome all of you on behalf of my ED sir, Kotwal sir, and our advisor sir, Dr. Jain Srivastav sir. Due to some meeting, they are not able to join with us. However, we are going to start the meeting on behalf of them. I am welcoming all of you. As we all know, there is a gap between the clinical practice and the knowledge of the standard treatment guidelines. And with that intent, we try to minimize those things through our standard treatment guideline talk series. And as of now, we have already covered 2 series. And this time we have started the third series of standard treatment guideline. And earlier with that, like first and second series is what we have on standard treatment guideline. Just let me tell you, just give you the number, how many participants were there actually. It's very overwhelming for Vice, and thanks to Sangeeta ma'am as well. More than 18,000 healthcare professionals, they have actually attended those sessions, and we have issued 2,600 certificates to those participants who have done both the pre and post lecture evaluation. And with this increased demand, so that's why we tried the third series. And one more piece of information I'm going to share. During those last 2 series, a few of the participants, they have attended all the sessions, and they have attended the pre and post, both the lecture, both the test. And today we are supposed to felicitate them due to their commitment, their dedication towards the quality and patient safety. But as Kotwal sir and Srivastav sir, they are not here. So in the next talk, we are going to felicitate them. And this third series, we are going to start. And so there is a one point in this series. This time we are going to focusing on not only the secondary care facilities but as the primary care facilities as well. So let's begin the session. And thank you so much, Sangeeta ma'am. And okay, now I'll hand over Aman to actually start the technical sessions. Thank you.
Thank you so much, ma'am. I would also like to invite Dr. Sangeeta Sharma ma'am, if you would like to say a few words.
Yes, as Chinmay has already told you, on behalf of DSPRUD and NHSRC, we extend thanks to all the participants, and the number is really very impressive. 18,000 of you pan-India, from different levels of healthcare, from different settings, primary, secondary, tertiary care, medical college. And when I was looking at the composition, many of the super specialty doctors from that and private sector also had joined, but majority were from the government sector. But certainly around 35% people were from the private sector as well. So that's very much encouraging. And the feedback from the field also has been really good. I thought 2 series are enough and we should stop it, but then I continued to get, messages from NHSRC. Staff of NHSRC has been going to the field, and people had been, recommending this program, and it really helped them in upscaling their knowledge and some of the past practices, which were not so good, and what are the current guidelines. It helped them in understanding that. So we thank you, for that, and I hope this third series also becomes interesting for you. The topics again have been chosen from your feedback only, and where we find that there is some gap. So idea is to give you the outline, the concept or the principles behind it. We may not be able to cover each and every detail, but our experts here try to scale up right from primary care level to tertiary care level, and they actually know how to do it very beautifully. So I hope you will find this series also beneficial. And we, as I told you, we have Dr. Anup Warrier with us. He's a renowned infectious disease specialist, and he is really working very hard towards the antimicrobial stewardship, and vaccines being very important part of it. So over to you, Dr. Anup Warrior.
Thank you.
And
Thank you,
adult immunization is a not so well covered topic, so I hope you will enjoy this. Over to you, Dr. Anup.
Thank you. Just give me a moment to share the screen.
Yes, sir.
Yeah, I assume my screen is up there, right?
Yes, sir.
Okay. Yeah, so good evening all. So in next 30 minutes or so, I would like to take you through certain basics and also certain specifics about the adult vaccination in India. The idea is to give you a practical knowledge of certain key vaccines and to understand some of the new vaccines which are out there and how you can use them in those particular context. So initially, I would like to come forward with certain requirements or reasons why vaccinations are considered to be important in our context. So this is from the WHO, and it specifies the global cause-specific mortality among 21 major types of diseases. So if you see, the fourth is respiratory infectious diseases. So this means that along with cardiovascular diseases or myocardial infarctions and malignancies, respiratory infectious diseases is one of the predominant causes of mortality around the world. And we know that the people or the age group who has maximum mortality from this respiratory are towards the older age group, right? So again, this is from the same WHO report, and you see that the number of deaths, it goes up and up as the age increases. This is again an age standardized incident rate of lower respiratory tract infections, and you look at the India, which is in dark red, which specifies that the incidence among the different countries around the world, we have significantly high incidence of lower respiratory tract infections. So that is the reason why the importance of vaccinations to prevent respiratory tract infections gains much importance in our country. So it is not just respiratory tract infections which are important. A lot of other diseases like hepatitis A, chickenpox, diphtheria, measles, all these have caused outbreaks in our country. This is just a list of certain studies which have reported outbreaks, and I am looking at only adults. So outbreaks among adults. So diphtheria, chickenpox, hepatitis A, various kinds of influenza, meningococcal disease, hepatitis B, so a lot of kinds of vaccine preventable disease. All these are vaccine preventable diseases which has caused outbreaks in India. And to top it, we know that vaccines save lots of life. If you look at the number of lives saved or number of child deaths preventable through vaccination for various diseases like tetanus, measles, meningitis, diarrheal diseases, acute respiratory infections, and other diseases, you see that it's significant, going on to millions. do we know the prevalence of vaccine preventable diseases in India? We do. This was one of the publications about 4 years ago, which looked at various incidence and prevalence for influenza, pneumococcal disease, hepatitis, measles and rubella, and typhoid. So all these classical vaccine preventable disease are present in significant proportion in India, and it gives an opportunity for us, in fact a huge opportunity for us, to prevent these infections from happening. We are all well versed with the concept of childhood vaccination. All our children have got vaccination cards and immunization cards, but we are not so well versed or comfortable with the concept of adult vaccination and even geriatric vaccination. So this is the latest WHO concept of something called as a life course immunization. Okay. So the requirement for immunization or vaccination starts from birth and infancy and extends up to the older adults. So it is seen as a continuum rather than breaking it into childhood vaccine, adult vaccine, and geriatric vaccine. Now WHO prefers to consider this in a continuum of what is called as life course vaccination. So probably over time we would be devising cards not until the age of 12, not until the age of 18, but until the age of maybe 80 instead of as a concept of this life course immunization. Now, why adult vaccination is not caught up? We did not have national guidelines at that time. This is in 2020. This has changed. I'll show you the latest guidelines. And obviously, the awareness about the need for adult vaccination was low. This is the CDC's 2024 snapshot of the adult vaccination schedules. So on the left, you see the list of vaccines which were recommended. And on the right, you see the age group, the kind of dosage which is required, and also if there are any specific risk group that requires. Okay, so no need to read this or remember this. This is some chart sort of thing which we can have with us in our office, etc., to double check and verify before somebody asks for us a vaccine, to inform us whether it's a single dose, what is the kind of administration, is it subcutaneous, it is intramuscular. It could be difficult for us to remember all this at a time, so it's better to have a copy of this something on your desk. This is the aging proportion in our country. So if you look at this year by year, the proportion of elderly or older adults age more than 50 is increasing. And you did see in the slide on the life course immunization and also the WHO mortality for respiratory tract infections that it is above these age or the elderly that the impact of vaccine preventable disease specifically causing mortality is very high. So what this shows is that over time, there will be a significantly higher proportion of susceptible population in India, and hence if we want to keep the comorbidities and mortalities reduced and or static or even much controlled, then we need to think of adult vaccination and vaccination in the elderly starting from today. This is the global perspective on elderly vaccination in the elderly. So this is a slightly older one. This is 2018, but it has only improved after this. So on the left side, you see a lot of countries where geriatric vaccination has been promoted, right? And some of them are financed or funded by the government. Some of them are not funded by the government in certain countries. However, the primary focus among elderly has been influenza, pneumococcal vaccination, and herpes zoster. So these three vaccinations have been significantly promoted in lots of countries around the world to encourage, as I was mentioning you, the risk or reduce the risk of geriatric diseases and their morbidity and mortality. We have a lot of challenges when we talk about adult vaccination. Obviously, cost of vaccines is a problem. It's quite expensive. Couple of vaccines like varicella or herpes zoster, for example. We do not have enough awareness or enough training or enough publications out there that puts across the benefits and safety of these adult vaccines. We as healthcare professional doctors often do not recommend vaccinations in our outpatient clinics because we ourselves are not very comfortable and we ourselves don't take many of these vaccines. And because of lack of national guidelines at that time, and it is not a part of the universal immunization program, which is a government funded program, it is out of pocket payment, and hence only affordable people will take it. Even if you propose most of these vaccines, only an affordable person can take. So this was published this year, 2024. Okay, so we have the Indian consensus guideline on adult immunization in 2024, and most of the data which I'll be quickly taking you through is from this guideline, 2024 Indian consensus guideline on adult immunization. It lists down almost all vaccines available, okay, including yellow fever vaccine, which has got a very specific recommendation for a travel to certain geographical areas and not recommended. So I will be quickly taking you through a couple of common vaccines which you are all aware of. The presentation in this guideline is very, very structured and useful, because if you look at this, it gives you the type of vaccine, route of administration, the number of doses, how it should be stored, and in a snapshot it gives you both national and international guidelines. Association of Physicians, Respiratory Section, International Society of Nephrology, Geriatric Society of India, IMA, Gynec Societies, NHM, CDC, etc. And followed by the Indian consensus recommendation, which is an amalgamation of most of the major physician and infectious diseases societies, professional societies in India, right? So chickenpox, the consensus recommendation is for asplenia and complement deficiencies, immunocompromised in terms of chronic kidney disease or hemodialysis, heart or lung diseases, CLD or alcoholism, diabetes, and healthcare practitioners. Okay, so these are the things from the healthcare, from the Indian consensus that it is recommended. One of the things which we need to keep in mind when we talk about varicella vaccine is expensive, right? So when we promote varicella vaccine or talk about varicella vaccine, we need to understand why do we talk. So what happens if chickenpox has or develops into complication? So you see on the slide on the right side, the complications like meningitis, encephalitis, vasculitis causing cerebral infarctions, myelitis, and then finally post-herpetic neuralgia. Right? So these are the complications that can happen from varicella. And acute chickenpox itself can have problems like pneumonias and meningitis. It can also affect the mother in the third trimester and then impact the fetus or the baby. So vaccine efficacy in varicella is 82 to 85% for any form of varicella, any complication of varicella, and 100% for serious disease if you take the 2-dose regimen. So chickenpox is a disease with a potential for serious complications like pneumonias and meningitis and even cerebral infarctions. And it is a vaccine which has got very good efficacy, more than 80% for any form and 100% for serious disease. So that is the reason why we talk about varicella vaccine and we promote varicella vaccine. Coming to Tdap, Indian consensus recommends it for almost all the categories. Cost-wise, Tdap is on the expensive side. Hence, TD or tetanus diphtheria is nearly as good or as accepted as Tdap. Okay? Tdap contains acellular pertussis and the cost escalates significantly compared to TD or tetanus diphtheria. So ideally it should be Tdap once in 10 years, but TD is also sort of acceptable. Hemophilus influenza B vaccines, again a particular subgroup of immunocompromised, those who are having heart-lung disease, CLD, alcoholism, diabetes mellitus, and heart-lung disease, and also on the elderly, like age more than 50 years. Okay, so this is another vaccine which we classically think of only in patients who have asplenia or undergo splenectomy. So other than people who undergo splenectomy, for the rest of the immunocompromised group, like CKD and alcohol CLD or diabetes or elderly, we hardly consider this, and this is another option. This is not available exclusively as Hib vaccine. So we have to either use the pentavalent or hexavalent injection, which includes Hib. Coming to hepatitis A, we usually prefer 2 doses 6 months apart. The recommendations for providing hepatitis A vaccine in adults is limited to those who are having HIV infections and chronic liver disease with alcoholism, as per the Indian consensus. Now, just like how we looked at the varicella vaccine, here again we need to look at why do we advocate for hepatitis A vaccine. So hepatitis A vaccine, especially in the post-COVID phase, we see a lot of complications like macrophage activation syndrome or HLH. It is known to have neurological, renal, hematological complications, acute pancreatitis. It can progress and contribute to vasculitis. So hepatitis A need not be innocuous, self-limiting hepatitis always. It is known to cause a varied complications from CNS to renal to hematological to pancreatitis, etc. And the vaccine is extremely effective. So if you take 2 doses, the efficacy is 94%. Okay? So again, we have a disease which has got risk of major complications and which is preventable by a vaccine which is very effective at 94%. Hepatitis B, now it is almost a part of the universal immunization program. So our children get it at the time of birth along with polio. But if we have not taken the childhood vaccine in adulthood, pregnancies, immunocompromised, HIV, other immunocompromised state, including diabetes and healthcare professionals, all of us required to take the hepatitis B 3 doses. In highly susceptible or risky group, like patients who undergo dialysis and have frequent exposure to blood, or healthcare professionals who are again at exposure to blood and body fluids, we need to demonstrate response to the vaccine by looking at our anti-HBs titers 1 month after the last dose, that is the 3rd dose. Right? So this is also something which we should remember, that as healthcare professionals and in those who are susceptible to blood and body fluid exposure like hemodialysis patient, ensure that we test the antibody against HBs and show that we have responded. Human papilloma virus or Gardasil virus, this is a new entry, couple of years now. We have section of HP4 and also HP9, 1 ml, 2 to 3 doses at 0, 1 and 6. You see the recommendation from various societies, culminating in the Indian consensus recommendation that it can be given to immunocompromised, HIV, CKD, heart-lung disease, CLD, diabetes, and healthcare professional. The age group is from 9 to 14 for most of this thing, and it can be given max up to the age of 45. It can be given for both males and females also. Influenza, we have trivalent and quadrivalent. The society guidelines talk about yearly repeat at every single dose every year. There are certain high risk conditions, which pregnancy is one important condition where the complications from influenza are high. Live attenuated vaccine is also present, which is a nasal vaccine, which we hardly use nowadays. The consensus recommendation also advises that we can take it for elderly above 50, pregnancy and immunocompromised being at high risk, and diabetes and routine travelers are at mass gatherings where the contact isolations or distance between people to people may not be possible. Now, I want to spend a bit on the influenza vaccines because this remains one of the most common diseases and most common respiratory tract infections which we get on a yearly basis. So this was a publication from JAMA in 2022 of a meta-analysis of 6 randomized controlled trials comprising of more than 9,000 patients. So an influenza vaccine reduced major cardiovascular events by 34% and reduced the risk of acute coronary syndrome by 45%. Okay. So influenza vaccine has benefits beyond preventing or reducing the impact of influenza. It has got significant impact on cardiovascular risk and therefore reduces mortality. This is another systematic review and meta-analysis which looked at 5 randomized controlled trials, and it showed that not only cardiovascular mortality but also overall or all-cause mortality also was reduced with adherence and uptake of influenza vaccine. The WHO recommends us, India flu, to take it in April. If you look at the map where the WHO has asked for the timing, we come to the parallel lines, and that is April. What is advised for India is the Southern Hemisphere vaccine, which is again from the WHO. So Southern Hemisphere vaccine in April is what the recommendation from WHO is for flu vaccination in India. It's advisable both trivalent or quadrivalent. So both are fine. We need not always take quadrivalent. If it's trivalent, still it's fine. Now coming to MMR, this is recommended predominantly if you look at healthcare practitioners, okay, because we are at risk from patients and we can transmit it to susceptible patients, both pregnancy, neonates, bone marrow transplant and organ transplant patients, etc. So that's why it is important for healthcare practitioner to take the MMR vaccine. So if you look at it, it is recommended only for healthcare practitioners and those who have asplenia and complement deficiencies. Right. Again, if you look at the complication versus efficacy, on the left you see the list of complications which have been published for measles, starting from otitis media, laryngobronchitis, pneumonia, hepatitis, encephalitis, pneumonitis, including mortality. So measles is a disease which can contribute to both significant morbidity and mortality, and the efficacy of a measles vaccine 2 doses is 99%. Okay, so varicella, hepatitis A, measles, these are diseases which have potential for complications, worsening morbidity, and who have extremely effective vaccines. Meningococcal vaccine, predominantly we again think of this in the splenectomy group of patients. So along with that, in HIV infection and travelers and mass gatherings, like when people go to Hajj and Kumbh Mela, etc., also this meningococcal vaccine may be recommended. Pneumococcal vaccine, we have 2 types available. We have the polysaccharide vaccine with 23 serotypes, and we have the conjugate vaccine with 13 serotypes. In the West, we have conjugate up to 20 serotypes. Now, just like how we discussed about influenza, this is the effect of pneumococcal vaccine on mortality and cardiovascular outcomes. So 15 studies, more than 3.5 lakh patients, it decreased all-cause mortality and incidence of myocardial infarction. So just like influenza, pneumococcal vaccine also has benefits beyond just reducing pneumococcal pneumonia. So this is what we spoke about, the array of pneumococcal vaccines from various companies, from Merck, Pfizer, GSK, Serum Institute of India, etc. Mostly now we prefer the conjugate vaccine for pneumococcus. So we have just 13. These are the serotypes which are there in 13, which are there in 15, and which are there in 20. Even PCV13 covers between 60 to 75% of the serotypes which are seen in India. This is the schedule which is recommended in the CDC. They have used PCV 15 or 20 routinely, hence 13 is not figuring. So for us, it will be predominantly PCV 13 as of now. So the recommendation is to start with PCV, that is conjugate vaccine, and give a booster with Polyvax after 2 months. Similarly, if patients have received, or these patients have already been vaccinated with conjugate vaccine earlier, especially 13, then you can follow it up with the polysaccharide vaccine every 5 years until they reach above the age of 65. So please remember that it is only until and above they reach the age of 65. This booster every 5 years is required. Now, if they have taken polysaccharide vaccine initially, then we need to wait for at least 1 year and then revaccinate with conjugate vaccine. Okay, so I will just reiterate this because this is important. Pneumococcal vaccine, start with conjugate vaccine, give a booster of polysaccharide vaccine after 8 weeks. Right. If the patient has already received polysaccharide vaccine, wait for 1 year and then give a booster of conjugate vaccine. For immunocompromised, there are different regimens of both option A and option B, some of them for 1 year, some of them at 8 weeks, etc. Finally, the recommendation from Indian consensus is that all patients above age of 50, immunocompromised, HIV infection, CKD, heart-lung disease, alcoholism, diabetes, travelers, all of them need to be provided with a pneumococcal vaccine, and we have seen how the schedules are. Polio is not routinely developed. This is sometimes asked by Saudi government, etc., when we go on Hajj. So for a traveler, it is recommended. Inactivated polio vaccine, IPV, 3 doses can be given apart for 1 month. If we have already taken all the polio doses in childhood, 1 booster dose of IPV could be enough. The IMA recommends 2 doses of IPV. Respiratory syncytial virus, this is being now tried out in the West, again also against elderly. So the CDC recommends this for elderly above the age of 60 and also in pregnancy, during late pregnancy. It is not yet available in India, and the recommendation from the Indian consensus is also age more than 60 and pregnancy. Typhoid, the recommendations are for travelers and mass gatherings, but there are like IMA, etc., who have recommended for less than 18 years conjugate vaccine 1 dose, and for more than 18 years polysaccharide vaccine every 3 years. So we spoke about varicella, we spoke about influenza, we spoke about hepatitis A, we spoke about measles, all these which have complications and can be easily prevented with a highly effective vaccine. So typhoid conjugate vaccine is something like that. So in a young age group, if you give typhoid conjugate vaccine, even a single dose has more than 80% vaccine efficacy. So this is an important cause of acute febrile illness in India. Typhoid is 3rd or 4th among acute febrile, like after dengue and leptospirosis or scrub typhus, typhoid comes 3rd or 4th as acute febrile illness cause in India. So you can easily prevent that with a single dose of conjugate vaccine. Herpes zoster is one of the newer vaccines. This is quite expensive, 10,000 plus. So the uptake and the use has not been too well. The various bodies do recommend this. CDC for more than 50 years, Indian Society of Nephrology for more than 60 years, and APA also for more than 50 years. The consensus document from Indian consensus recommendation are again for age more than 50, immunocompromised, HIV, heart-lung disease. These are the proportions where the Indian consensus recommends the herpes zoster. Is the prevalence or incidence of herpes zoster important in India enough to consider this expensive vaccine? Right, it is 10,000 plus, so about 15 to 20,000 for 2 doses. So is it really worthwhile, and is it really important enough to use this expensive vaccine in India? So this is one of the studies from outpatient departments of various healthcare centers in India. So this compiled 27 studies from about 10 years, from 2011 to 2020. They identified 3,124 cases of herpes zoster from out of 27 studies in this 10 years. Herpes zoster neuralgia occurred from 10 to 54% of cases. So about 10 to more than half of these cases in various studies developed herpes zoster neuralgia. And we know that the predominant issue with herpes is neuralgia. There are rare complications of herpes zoster like myelitis and cranial nerve palsies and hepatitis, etc., which are extremely rare, but is still possible. The majority of them, their complication is what we talk about, the post-herpetic neuralgia. So 2 vaccines are there, but what is available with us most commonly is Shingrix from GSK. So 2 injections, 2 to 6 months apart, and it is again quite effective, 97% effective. It would seem superfluous to talk about COVID boosters in the present scenario, but I just want to give a brief on what WHO talks about COVID boosters. So this is the WHO table from the document which I showed you regarding COVID boosters, and older adults, comorbidities, and those who are healthcare workers. All these come under the recommendation for the booster dose. So booster dose is the 3rd dose, that is 1 year after the last dose. Okay. So minimum 3 doses are recommended by the WHO. So 1 booster for all is sort of recommended by WHO in these high-risk patients. Which kind of vaccine should we take? Heterologous vaccines are fine. So it need not be that you need to take the same kind of vaccine or the same brand of vaccine or same valent vaccine as you have taken before. A different kind of vaccine is also fine. Now, based on certain category of population, there are certain specific recommendations. I will not read through all this, but just to highlight to you that based on certain populations or category of population, there are a set of vaccines which are recommended. So this is the set for healthcare personnel, and we have similarly a long list for recipients of bone marrow transplant. We need to remember that once the transplant is done, it wipes out their vaccine memory. So even childhood vaccination needs to be repeated after the bone marrow or before. So hence they have a long list of vaccinations. Solid organ transplant, both kidney and liver. So they also have a list of recommended vaccines like pneumococcal influenza, hepatitis, and Hib. So this is something which, again, like what I showed you for the CDC table for age-wise vaccination and schedule, something which we can keep on the table, where based upon the age group, the Indian consensus and recommendation is available in a single snapshot. So if they are 18 to 49, what are the vaccines to be considered? 50 to 64, what are the vaccines to be considered? And above 65, what are the vaccines to be considered? We have a specific set of recommendations for immunocompromised also, that is other than bone marrow transplant and other than solid organ transplants. There are different categories of immunosuppression, and predominantly these are people with significant rheumatological diseases like Crohn's disease, rheumatological arthritis, rheumatoid arthritis, SLE, etc. So when we vaccinate them, it is important for us to understand whether they are on low level immunosuppression or are they on high level immunosuppression. Because if they are on high level immunosuppression or planned for high level immunosuppression, we should as well vaccinate them 2 to 3 weeks before. And if they have already received high level vaccination, you should probably wait for a couple of months. Like rituximab, etc., has a long tail of about 4 to 6 months. So the vaccination can only start after that. But if they are on low level immunosuppression, you can probably start along with that and even complete the vaccination along with the treatment for the immunocompromised, the autoimmune disease. So that is why this is important to understand which are the category which comes in high level immunosuppression and low level immunosuppression, because it determines the timeline you want between vaccination and their treatment, and whether you can continue vaccination along with their treatment. So to close the session and give you a short summary of what this is about, 3 vaccines are strongly recommended with the evidence of benefit. And what is this benefit? All-cause mortality, cardiovascular events and cardiovascular mortality. Based on this, influenza, pneumococcal vaccine and COVID with the booster, these 3 doses of COVID, they are strongly recommended. Influenza has to be taken annually. The WHO says in April, and southern hemisphere, trivalent or quadrivalent is fine. Pneumococcal vaccine, pneumococcal conjugate vaccine is the initial vaccine of choice. We follow it up with PPSV 23 after 8 weeks. COVID vaccination of 3 doses to be completed. Benefits are more than risk. Healthcare professionals come under the WHO category of where it is strongly recommended. What are the other vaccines relevant? Varicella, typhoid and hepatitis A, where the complications are possible. And here probably you could include measles also, where significant complications are possible, and vaccines are extremely effective, 80, 90, 95% effective. We also have the newer vaccine, herpes zoster, and we know that the incidence of herpes zoster, though not very common, the association with neuralgia is there. From 10 to 15% of those who develop herpes zoster develop neuralgia, and it causes significant morbidity, and an idea is to reduce that incidence. So I'll stop here, and I will be happy to take any specific questions or queries if there are any.
Thank you, Dr. Anup, for a very lucid description of adult vaccination. You've answered many of the myths and the efficacies that we find, what is the current situation. If there are any questions, you can write in the chat box. We'll be happy to take those questions. Some of it was, herpes zoster, while these people are writing, most of us of our age group have got chickenpox during our childhood. So should we be taking a herpes zoster vaccine?
Yes, so prior infection or immunity for varicella is not a contraindication for herpes zoster. We know that even though both are from the same virus, one is a manifestation of latency with reactivation, and while other is a manifestation of an acute infection. So an acute infection and latent presence does not provide us protection against herpes zoster. So the herpes zoster vaccine is not dependent upon whether we had chickenpox or we did not have chickenpox. Irrespective of that, we are expected to take the zoster vaccine.
Because generally we believed, initially that those who had chickenpox in their childhood will not get herpes zoster. So that was the kind of misbelief that we had. So now it is clear that we can take both. Even we had the chickenpox, herpes zoster vaccine would be, and the neuralgia would be much less with the, if you still get the infection. Otherwise, post-herpetic neuralgia is very troublesome. Okay, Dr. Warrior, I'll read out the questions one by one. There are few questions in the chat box. Before we proceed, there was one mistake in the pre-test regarding the missed dose. We have corrected that. That was about the missed dose. Third dose of DTaP was, if it is missed, what do you do? So the correct answer is that you administer the missed dose as early as possible in this visit and resume with the, schedule the fourth dose after 4 weeks as per the plan. So please make a correction. So we will not count that for evaluation purpose. Okay, let's go to the. We will share this guideline link with you, adult vaccination. I think this is available on the internet also. You can download directly.
Yes, it is available.
Even I also saw that. Sir, can you share PPT? वो मिल जाएगा आपको. Don't worry about that. Are hepatitis B booster dose vaccination still in, or it's just the 3 doses for life?
So the classical recommendation or belief is that if you have an anti-HBs titer 1 month after the third dose, that is at the 6th month, and then you check the titer 7th month or beyond. And if it is more than 10 international units per ml, so that means you have responded to the vaccine. So you are a vaccine responder. So the classical teaching is that if you're a vaccine responder, that's all. So you need not take boosters, etc. Because with every exposure, if you have an exposure sometime, it will actually act as boosters. So we see this in many surgeons who have titers of more than 1000 IU per ml, because they have constant or intermittent exposure to blood and body fluids, and that it acts as booster. The titers are way above 1000 and all. So the key thing is to ensure that you are a responder, and that's something which is not uniformly done. So we need to look at anti-HBs titer, prove that it has reached more than 10 anytime after this vaccination. Then you are a responder, then boosters are not required. There is some difference in terms of this value. Is it 10 or is it 100? Some of the professional societies, especially the GI, gastrointestinal professional societies, gastroenterology professional societies, and some nephrology professional societies also prefer a titers much higher. So they look at titers of more than 100 as protective. And in these where high risk group where these exposures are common, they look at the titers intermittently over a year or so, and if they see falling below 100, they advise a booster for that. But that is it is only a minor professional society recommendation. The broader CDC, etc., stops it at 3 doses, prove you are a responder, and then no need of booster.
So, Dr. Warrior, can it happen? I achieved the titers, the recommended titers. Will it fall over a period? Maybe if I repeat after 1 year or 2 years,
yes,
it happen.
So, yeah, so titers have to fall because that is the natural course. Like when we give a vaccination, you stimulate the both T cells and B cells. So there is a flush of antibodies. Then those B cells antibodies settle down, and you have the memory T cells. So for any vaccine you take, the idea is that you have your memory T cells ready to produce your antibody when there is an exposure. You need not have always a neutralizing level of antibodies in your body. The idea is that you prime your body, the memory T cells, to be ready. So even though after a year the titers go down, the moment there is an exposure, your memory T cells will jump in, produce the antibodies and neutralize. So that's the concept of the vaccination part.
So that is the reason we say that. Yeah, there is no need for booster then.
No need for. That is the reason we are saying that. That is the reason we say that we need to look at the anti-HBs titer 1 month after the third dose. Because if you do it after 1 year, if it is low, you don't know. Is it low because it has naturally fallen, or is it low because you are not responded at all?
Okay. Thank you. Then there is a question, can we take vaccine even after affected by the disease and recovered already?
So there are few diseases which give you immunity similar to what the vaccines gives you. Okay. So varicella, mumps, measles, hepatitis A. So these are the diseases that gives you immunity equivalent to vaccination. So if you have these naturally acquired, taking vaccine after this will not give you any added benefit. Why? Because the efficacy of vaccine is similar to the natural history. It is not going to give you anything more. But there are some diseases which do not give you immunity, like typhoid. You can get typhoid again and again, right? While the vaccine gives you good protection against typhoid, the natural infection does not give you that good protection. So if you have typhoid, even if you had typhoid, once you've recovered well and later, it's still worthwhile to get a typhoid vaccine. But I would not recommend varicella, measles, mumps, or chickenpox, etc., because the natural disease gives you as good as an immunity as a vaccination.
Dr. Warrier, there is outbreaks of measles are being reported now. You know, age group who have completed their childhood immunization. Do they need to worry about this outbreaks of measles?
See, the MMR requirement, and we are talking about adult vaccination, and the MMR requirement spills over to the adult age group also. So if we have completed our childhood schedule of MMR, we require at least one booster in our adulthood. So if you are not taken even one booster after the age of 18, as time goes, you will become susceptible to measles again. The same thing is applicable to mumps also. Like in Kerala, we had an outbreak of mumps in Ernakulam, the same district where I practiced. We had an outbreak of mumps also, especially because the government had changed here from MMR to MR. So mumps was removed and measles rubella was the vaccine included in the universal immunization campaign. And hence, a lot of people were missed out of mumps in their childhood, and we had a mumps outbreak. So both for mumps and measles, after you reach adulthood, after the age of 18, at least one booster will help you.
Okay, thank you. What is your answer to a person with allergy with egg? Do they not take the vaccine then? There was a question about food allergies, whether this affects the vaccination. Some people.
So a couple of vaccines are egg-based. So most of the influenza vaccines are egg-based vaccines, etc. So if you have serious allergy to egg, serious allergy meaning anaphylaxis, urticaria, angioedema, so these hypersensitive reactions, then these kind of vaccines which are egg-based are contraindicated. So if your allergy is of minor kind, like you had some bit of maculopapular rash which subsided with antihistamines and all, and if you are you fall in that extremely vulnerable group, then the risk versus benefit is that you take the vaccine, right? Because the chance of allergy is there, but it is lesser. Plus, even if it happens, it is a milder kind of allergy. But if you have anaphylaxis, angioedema, urticaria, we can't take that risk of a potentially life-threatening allergy. We can't take that risk. So then it becomes contraindicated.
Or you take the precaution that you do this vaccination in a setting where you can take care of these.
Absolutely.
If it is. Okay. Then next question is, a 64-year-old has suffered from herpes zoster about 11 months ago. Should he take herpes zoster vaccine? If yes, when?
So if somebody has already had herpes zoster, still in terms of recurrence, etc., this vaccine may help. But I wouldn't strongly recommend that he needs to take a second vaccine. So it would come under sort of, may be taken sort of thing. And if you thinking about taking it, 1 year would be the appropriate duration.
Then I think HBV booster, somebody's written that, please explain this again. I think he has already emphasized this very clearly, that you have to look at the responder. First you demonstrate that you have responded to the hepatitis B vaccine, and even later if the titers decline, once you are a responder, you need not worry. There is no need for a booster again. Then there is a question about adult vaccination is not part of the government program or reimbursed by insurance, including this. How to go about it? I think that also is.
Yeah. So obviously, as I was mentioning in my initial slides, the uptake of adult vaccines has been poor predominantly because of the finance. And there are a couple of vaccines which are extremely expensive. Herpes zoster vaccine, as I told you, costs some 10,000 plus, extremely cost. So unless there are mechanisms by which they are reimbursed, etc., the uptake is going to be poor. Even pneumococcal vaccine is on the expensive side, like 7,000, 9,000 range. So when we prioritize, okay, so one of the things when things are expensive and resources are limited, what we do is we prioritize. So we prioritize by two things. One, we prioritize by the host vulnerability. Like, so you need to ask yourself either about your condition or the patient's condition whom you are advising, how vulnerable they are. Okay. Second thing which is look at is that what is the benefit, or what are the vaccines which are shown to be highly beneficial. So that's why in my concluding slide I divided it into 3 groups. First group, where there is significant mortality benefit going beyond the prevention of those particular infections like influenza and pneumococcal. So these definitely you should take, and definitely you should advise, because compared to their cost, the benefits far exceeds that. Like, you know, all cause mortality, cardiovascular events, so a lot of benefits beyond this. So you should definitely take that. Then we have those which have an impact on morbidity, like chickenpox and measles and hepatitis A and typhoid, etc. So those you look at whether it is possible, if the cost is manageable, do you have the ability to take, etc. Because as I told you, it is not like influenza where there is a significant mortality benefit. You are looking at morbidity, and in extremely vulnerable, and if you have an ability, you can take it. The last are to be considered or good to have sort of thing. So herpes zoster is of that thing, good to have, because it is not a fatal disease. The vaccine is not going to give you any mortality benefit. It only reduces the incidence of neuralgia by about half. So it would be the last preference in terms of cost and in terms of efficacy. So that's how I would prioritize and decide if I have limited money.
Okay, I think that's a very good yardstick to evaluate. Even for medicines, we do that. Okay, there is a question about why flu vaccines are contraindicated above 65 years of age.
So inactivated vaccine can actually be given above the age of 65. So all vaccines need not be contraindicated above the age of 65. Live vaccines we don't, but inactivated vaccines can be provided even for the elderly.
Okay. I think what about combination of vaccines can be administered at the same? I think Dr. Grube is already there. He will address these things during his presentation. We can keep this question for him. Please explain TT booster dose, or how often it can be given in industrial sector.
So if you have completed the childhood vaccination schedule, okay, then the recommendation is that you receive a tetanus, diphtheria, TD or Tdap, whatever. So there is no TT alone now. So all the guidelines talk about either Tdap or TD, not TT alone. So Tdap or TD once every 10 years. So every 10 years you require a booster for TD or Tdap. Okay, after you have completed your basic schedule. So if you do not know whether you have completed your basic schedule or you have not completed your basic schedule, then you need to first complete your schedule. Okay, 0, 4 weeks, 6 months, etc. So complete your basic schedule, then come on to those boosters every 10 years. Now, what if an injury happens in between? So if it is a significant contaminated injury, then within 5 years, if it happens, you need to take a booster. Okay. So for mild injuries and uncontaminated, non-contaminated injuries, 10 years is fine. So again, I will repeat, take booster every 10 years. Between these 10 years, if you have had a serious injury, especially contaminated injury, if it is under 5 years, you again need to take a booster. Okay, not under, sorry, above 5 years. If it is above 5 years, you again need to take a booster. If it is a minor injury, you need not take it, because it protection lasts until 10 years.
Current practices, even anyone gets a minor, वो nail लग गया है या barefoot था, minor injury था, people give tetanus injection, but if the vaccination is complete, there is no need. But people they have so much of fear of tetanus that they take,
so,
and they think.
Very important thing is that many of us, even when we don't complete the schedule, and half of us at our age, we don't know what we have taken in childhood. So if at all we start taking the TT or TD and you don't know what has happened in childhood, always remember to complete the schedule so that you are protected for next 5 to 10 years.
Okay. There is a question. I had taken HBV full course long ago. I have not checked that the titers 1 month later after the last dose. Then what to do now?
So one of the things, so in this situation, what we do is that we take a single dose, take a booster, take 1 shot of hepatitis B now, and check your titer after 1 month after that booster. So if you are a responder, again your titers will go up after this booster.
Okay.
So you can still do it.
What about after needle stick injury for healthcare worker where the source is hepatitis B positive?
So the CDC guideline for post-exposure management, it talks about the classification is that do you know that your titer is more than 10 anytime before, or do you don't know the titer, or you know that your titer is less than 10. That's how it classifies. So if you know that you have achieved a titer of more than 10, you are protected. So nothing more is needed. You don't know your titer, you need to check your titer right then. Right? So if it is more than 10, you are protected. If it's less than 10, you don't know whether you have responded, whether it will go up, you don't know. You take the vaccine and the immunoglobulin. If you know it has been less than 10 and you are a non-responder, take the immunoglobulin along with the vaccine.
What are the vaccines recommended for diabetics?
Almost all. So diabetes remain a very vulnerable category with risk of both significant disease manifestations and mortality. So influenza, pneumococcal vaccine, the herpes zoster, for example. So almost what we saw, if you look at the recommendation, almost all of them recommended for diabetes. So as I was saying, in terms of priority, influenza, pneumococcal, definitely. So these are the two definitely you should advise. The rest are optional.
They are immunocompromised. They are considered as immunocompromised, so it gives them the benefit. Okay, then there is a question about kitchen worker. Should they be vaccinated with typhoid vaccination?
So the FSSA recommendation, the Food Safety Authority recommendation is that they should be vaccinated against foodborne illnesses. So they don't specify typhoid or specify any other disease, but what they say in a general sense is that should be immunized against foodborne infections. So most commonly available foodborne infections or commonly available foodborne infection vaccines are typhoid and hepatitis A. Right? These are the two things, and we know that in terms of transmission also, typhoid has a the points, or we all know the typhoid Mary story, etc. So the potential of transfer from a single source to many is also high for typhoid. So that is the reason why we do recommend and we do advise typhoid vaccine for food handlers, especially and the NABH accreditation bodies and all, they do ask and look for it.
What about hepatitis A? Can it be?
Hepatitis A or too, hepatitis A also, but like I was saying, the risk of an outbreak, large outbreak is lesser compared to typhoid, but still hepatitis A is also foodborne illness, so we do give.
But again, healthcare workers, they have occupational hazard here and.
True.
How many how frequently typhoid vaccine is required?
So if you are using polysaccharide vaccine, you need to give it every 3 years. But if you are using conjugate vaccine, maximum 2 doses. The most of the general guidelines say single dose of conjugate vaccine, but one after 2 years should be suffice even with nothing further than that. But if it is polysaccharide, you need to take every 3. We have stopped using polysaccharide vaccine now. We regularly use only conjugate vaccine. Much easier, simpler schedule.
Again, that question is, if you don't remember your childhood vaccination, will it be harmful if we get the full course vaccination?
No, we can take, you can complete the schedule of all the major vaccines. So a couple of things which we don't have much risk is polio, right? So I wouldn't go ahead and take the full course of polio because that's not something as an adult we are exposed to or nor at a high risk. It's extremely unlikely for any of us right now to be exposed to polio, and so because we have good herd immunity also. So I wouldn't repeat the polio schedule, but rest of them, yes.
Dr. Sunil Khetarpal, you've written 1 year from the onset or recovery.
This is for the herpes zoster question. Yeah, this is for the herpes zoster thing. So it is 1 year from the recovery, not the onset. 1 year from recovery that the next or herpes zoster vaccine can be taken.
Okay. What about cancer vaccination?
Vaccination in cancer patients or vaccination against cancer, because both are there. Actually, like Gardasil, for example, human papillomavirus, it's almost like vaccination against cervical cancer, right?
Okay.
And then there is vaccine for cancer patients. So vaccination for cancer patients is obviously, it comes under the immunocompromised group, and I gave you a list of what would compromise of severe immunosuppression, like in the table, severe immunosuppression, mild immunosuppression. So if they come under severe immunosuppression, the timeline, what you can give, can you give inactivated live vaccine, what should be the timeline kept, etc., should be very carefully looked into so that you can ensure that the vaccine you give actually does its job. But otherwise, most of the things which we discussed here are applicable to the general oncology patients also. Only thing to remember is to understand whether that high risk highly immunocompromised or less immunosuppressants, and based on that to adjust your timeline of vaccination.
There is a question about childhood and adult vaccine formulation. Are they same?
For a couple of them, yes, but most of them, no. For example, say hepatitis B, we know childhood 0.5, for adult it is 1 ml, so it does differ.
I think you've already answered this question. For adults, TT or TD or TDP?
So the difference between this is that TT now it is not recommended anywhere. All the guidelines they have pushed out TT, so it's only TD versus TDAP. The only advantage of TD against it is that it is cheap. So if you avoid pertussis, it is significantly cheaper. If you include pertussis, it is on the expensive side. The recommendations, ideal recommendation is TDAP. So scientifically, if you ask, it is TDAP. Cost-wise, TD.
Any vaccine which is completely contraindicated in immunocompromised population?
Yellow fever, for instance, and most of the say varicella, for example. So these are the live vaccines which have a potential to cause significant disease in immunocompromised. And as I mentioned, that severely immunocompromised group. So here we definitely avoid live vaccines, especially things like yellow fever and varicella.
Also, live vaccines are avoided in contraindicated in pregnancy.
Yes, because of the fetal impact.
Yeah. Is HIV vaccine available or still in clinical trials?
Not available still.
I think, should HPV vaccine be given to boys and men too?
Yes. So it is applicable to both with the specific age group differences.
I think there are no more questions. We had a marathon question round, and you had been very, answering them very clearly. Oh, one more question. 8-year-old boy completes his leukemia treatment. So which vaccine we can give him?
So if has undergone only chemotherapy, usually after 6 months of chemotherapy, the effect or immunosuppression from the chemo regimens are minimal. So you can, the age appropriate vaccine, because he's 8. So that means his childhood vaccination is still incomplete. So you have to look back also, because of this disease and all, has he missed anything of his regular childhood vaccine? That often happens, because when child falls sick, they are unable to stick to their childhood vaccination schedule. So remember to complete their childhood vaccination schedule. And if the first is that, confirm whether you have missed childhood vaccination, complete the childhood vaccination, then you come back and go back to the regular schedule, what is called as catch-up immunization, right? So what is missed out, reach that age appropriate limit. So that's what I would advise. And initiation, as I told you, about 6 months after the chemo.
I think there are no more questions. We must thank Dr. Anup Warrier for sparing his time. He's a very busy, infectious disease. And one thing I would like to share with you, there is a scarcity of infectious disease specialists in the country. They are much needed, but there are very few specialists available. And he's been very kindly associated with DSPRUD for many, many years. Our stewardship course that we run on antimicrobial stewardship. He's one of the very what do I say? The core faculty for this. Thank you, Dr. Anup Warrier. I hope you are staying back for Dr. Dubey. If not, it's okay.
No, I'll check out. Thank you.
Okay, thank you very much.
Thank you. Thank you so much, Anup sir. It was a very informative session from you. Thank you once again for the session, sir.
Thank you, Dr. Aman. Thank you.
Dr. Dubey, can we have his...
good afternoon. Good afternoon.
Good afternoon, sir. कैसे हैं? Good to see you. Good to see you. Okay, I think we have already introduced you and you were not, logged in, but still once again, I would like to introduce Dr. Anand Prakash Dubey. He's a very well-known pediatrician, retired as Director Professor, Department of Pediatrics, Maulana Azad Medical College, and he has done fellowship of Indian Academy of Pediatrics, WHO fellowship in UK. So a lot of accolades to him, and he had a very long, excellent academic career. With clinical and academic experience of over 45 years. He is president of Indian Academy of Pediatrics, Delhi, and has been honored recipient of Delhi State State Doctors Award and has immense collection of over 90 publications in various national as well as international journals. I think, sir, आपने वो नहीं लिखा, आप AEFI कमेटी के मेंबर हैं.
ये पुराना है, आपने कर दिया. ये पुराना है. पुराना है when I was the president of IAP.
वो उससे sir, the experience, because you were looking at the national level, the about the reports coming about the reactions to vaccines, so that your experience as a chairperson is really very important. So over to you, sir.
Thank you very much. I think you are putting up the slides.
Yes, sir. Just give me a minute. I'm putting up this slide.
Yeah, please. And Dr. Warrier has very well covered the adult vaccination, which is very few people talk about the adult vaccination nowadays. Most of the time it is childhood vaccination only. So I was really very pleased to listen to him, and he has answered most of the questions very well. So nice. So this is we are all aware that we give vaccine for preventing the diseases. So therefore, we also presume that the vaccine which is being given should be all safe. Safety part is the most important. And therefore, whenever any vaccine is being approved by the government or the DCGI, the Controller General, safety part is the one which is kept in mind, because the vaccines are given to the healthy individuals and for prevention of disease. So we do not want that they should have side effects. So any vaccine which has got very good immunity or which works against a condition and then have a very few side effects, if at all there, that is the good vaccine or best vaccine. So therefore, whenever we give vaccine, there are certainly some side effects are bound to happen. And those are also known as, or we categorize them as, adverse events following immunization. So I will cover that, what are those kind of minor and major kind of adverse events which do occur after the vaccination, and then how to categorize them, classify them, and what is their management. This management is not a very big deal here, because we will be according to the condition we have to manage. But in any case, I will cover that also in one slide. So next slide, please. So please remember that to classify or define AEFI, or what is known as adverse event following immunization, is any untoward medical occurrence which follows immunization and which does not necessarily have a causal relationship with the use of the vaccine. So it is not that you are aware of certain side effects of the vaccine and then those who occur after that or who are known, you will define them only as AEFI. If any untoward medical occurrence, it can be an unfavorable or unintended sign. For example, any excess following vaccination or the vaccination site for that matter. Abnormal laboratory finding, just like thrombocytopenia after measles vaccination. And or it can be a symptom or a disease even, like disseminated BCG infection following BCG vaccination and so on. There are many other symptomatology or some conditions which may occur following a vaccine. So therefore, anything which is occurring after immunization and which may not have a causal relationship, still we should be define them at the AEFI and should be recorded and reported. Thank you. Next slide, please. Right. So for purpose of reporting, when you have to report it, they can be either minor, severe, and serious. Please remember there are three different: minor, serious, and severe. Minor is, these are the common self-limiting reactions. They usually occur within a few hours of injection and resolve after a short period of time, and they pose little danger. For example, pain, swelling, redness at the site of injection, mild fever, irritability, malaise, etc. So they do not have any much problem. Moreover, the severe and serious, now the major ones have two categories: severe and serious. Serious can be disabling and rarely life-threatening, although they do not lead to long-term problems, but they have to be reported and have to be kept in mind, because sometimes severe can become serious also later on. So the examples of severe include non-hospitalized cases of anaphylaxis, which immediately occurs. It is a very serious kind of issue, but it is known as severe because it may not require hospitalization. So anaphylaxis, which is recovered, or high-grade fever, and so on and so forth. And later on, the last is the serious one. Serious ones include death following a vaccine, inpatient hospitalization, any hospitalization after the vaccine has been given is in a serious category. AEFI cluster. What is a cluster? I will define later on. Any vaccine which may result into congenital anomalies. So anomalies noted after the vaccination, it has to be a serious kind of problem. And lastly, anything which evokes significant parental or community concern. So if there is a vaccination drive going on or mass immunization campaign and there is a significant parental concern that many children have suffered from some kind of problem, and this was moreover in the past once autism, which was related to MMR vaccine, although it was not proved. So anything which has got a parental or community concern is in a serious category. So please remember, these are the three main: minor, severe, and serious. For the reporting purpose, three types. Next one. Next slide, please. So to elaborate further, the minor reactions, they usually occur within a few hours after the injection, mostly injectable vaccines, resolve after a short period of time and pose very little danger to the recipient. They include local ones like pain, swelling, or redness at the site of injection, which will subside over a period of time, maybe in a very 40 to 72 hours time maximum. And it can be systemic as well, like fever, malaise, muscle pain, headache, loss of appetite, and so on. And many of you must have, I think, after COVID vaccine, observed or suffered from some of these, maybe malaise, muscle pain, headache, or loss of appetite, or sometimes not feeling well, but for a short period. So these are minor reactions, although these are also to be recorded so that we know that yes, these reactions do occur after the vaccine, and therefore there is no cause of worry or don't panic after the vaccine has been given. Next one. So again, repeating the same, the local ones like pain, swelling, redness at the injection site, and systemic ones like fever, irritability, and malaise. And more so, this may cause some kind of discomfort to the person, or especially the children. Moreover, that they may become irritable, they may not take proper feeds for some period of time, they may have fever also. But yes, these can respond to the medicines, and therefore there is not much to worry about these vaccines. There are some vaccines which are more reactogenic and may lead to local as well as systemic reactions. Some of them may have only local reactions. These are all minor ones. Next. So what is the scientific reason behind this? These are caused when the recipient's immune system reacts to the antigens which are contained in the vaccine. So any vaccine which are given contains an antigen, and the body reacts, its immune system reacts against that particular antigen by producing antibodies, and therefore some of these may manifest as fever, or for that matter malaise, body ache, and so on. The immune response to the vaccine's antigen can cause local and systemic reactions like pain, fever, swelling, loss of appetite, etc. Other vaccine components can also trigger reactions. So it's not only the antigen, but sometimes, most of the time, these vaccines do have adjuvants, stabilizers, preservatives, so that the vaccine can be kept for a longer period of time. Or there are multi-dose vials where there is an open vial policy, and you can use the vaccine even after one dose has been given, second dose you can give after some time. So preservatives are being used, and to stabilize and to increase their potency, adjuvants are being used. So therefore the reaction can be, hello, somebody is not audible, I don't know why. Maybe at their own end they have to see. Am I audible otherwise?
Yes, sir. You're perfectly audible.
Good.
Please check your internet connection or the device setting.
Okay, thank you. So other vaccine components can also trigger these kind of reactions, and therefore we have to keep in mind that it's not only the vaccine antigen, but yes, stabilizers and other vaccine components can also cause. Therefore, somebody was talking about the egg allergy. So yes, if the vaccine contains some component of the egg or neomycin for that matter, antibiotic, and if there is allergic to that particular component of egg or antibiotic, he will have that kind of reaction. So therefore, these reactions can be either because of the vaccine antigen or can be because of some other components of the vaccine. Now, to define a good vaccine, as I said before, an ideal one which keeps even minor reactions to a minimum and producing the best possible immune response. So we always try to develop a vaccine. Therefore, there is always a kind of say research going on that yes, we should have some vaccine which has got very few reactions. Say, for example, oral polio vaccine. Oral polio vaccine can cause what is known as vaccine-associated palliative poliomyelitis. It is a live vaccine. So therefore, we have another vaccine which is injectable or inactivated polio vaccine, which does not have that kind of problem. So it is an improved vaccine, you can say, and producing good immunity also. So we always try to have, or the scientists always try to develop a good vaccine which has got very minimum minor reactions and maximum immune response. So minor vaccine reactions are part of the body's immune system and occur more often than severe, but usually they respond or they heal within a short period, and therefore self-limiting condition should not bother much about these problems. Next one. So these are the, you can see the rates of various reactions that are associated with childhood vaccines. Please remember, we are talking about childhood. So hepatitis B, for BCG, for example, pain, swelling, redness, almost 90 to 95%. This is a reaction which is a normal reaction after the BCG vaccine. When we give in the childhood or at the time of birth, the child will develop in that area swelling, then papule, pustule, and ultimately it will heal by scar. So scar formation is one of the, I even say, positive thing that the vaccine has been taken up. Hepatitis B vaccine, again, same thing, 15%, Hep 5 to 15%. The most reactogenic out of this is DPT vaccine, where you have pertussis part, DTWP, for example, up to 50% may have fever. So this is the most reactogenic whole cell pertussis vaccine. And as I was talking about, now the people have developed what is known as DTAP, diphtheria, tetanus, acellular pertussis vaccine. Acellular pertussis vaccine has a very minimum. This has 50% fever. There, the fever rate is not more than 5 to 10%. So pain, swelling, again 50%. So there are some vaccines which are more reactogenic compared to others. So please keep in mind that these kind of systemic reactions and local reactions, minor ones, can occur, and then there is no cause to worry, and they will respond to the symptomatic treatment only. Next. Next slide, please. So there is now we come to the, after the minor, the severe ones. Now please remember, severe and serious, these are the two different categories. So first, severe ones. They usually do not result in long-term problems or rarely life-threatening, and they include seizures and allergic reactions caused by the body's reaction to a particular component in a vaccine. So as I said, if it is hospitalization, it becomes serious one. But if there is high-grade fever, for example, seizures which have responded to the emergency room only, or some kind of allergic reaction which will subside after a certain period of time, they will all come into the severe category. So severe reactions are, these are the ones. Again, next one, we will give some example, we'll see. Now these are the severe reactions. Now, this is the, say for example, BCG, dissemination of BCG infection, which can occur even up to 12 months after the vaccine has been given. But yes, the rate frequency is very, very low. You can see here, very, very low frequency, so very minor ones. Similarly, OPV, VAP, vaccine-associated palliative poliomyelitis, can occur up to 30 days, and then you see the 2 to 4 per million doses. DTWP, here the chances are more often with severe prolonged crying and seizures, or hypotonic hyperresponsive episodes, or febrile seizures for that matter following measles, or even this DTWP. They are much more common. You can see 1 in 3,000 is the rates for febrile seizure. Thrombocytopenia is 30,000, 1 in, and this is 1 in 1 lakh. So these are the, anaphylaxis is extremely rare. You can see here. But yes, these are the severe reactions, and they do respond to the treatment very well, do not result to a long-term problem or serious kind of problems. So please remember this, that yes, they do occur. This is the frequency, very few, but yes, they do respond to the treatment very well. Next one. Now we come to the serious ones. Now the serious, these are the only few categories of serious ones. Please remember, these are specific categories. These are the only ones which are serious and therefore known as SAE, serious adverse events. These are death following any vaccine, inpatient hospitalization or hospitalization will come into this category. Persistent or significant disability. Somebody has got permanent disability. For example, polio vaccine-associated poliomyelitis. AEFI cluster, I will define cluster later on. Any vaccine resulting in the congenital anomaly, that is a serious problem. And finally, parental or community or media concern. Next one. So it can be disabling and rarely life-threatening severe reactions, whereas the serious ones are these categories. So this is the difference between the two. Severe ones can be disabling, but do not lead to long-term problems, and they also have to be reported. Whereas serious ones will result into death, hospitalization, significant disability, birth effect, clustering effect, or community or media concern. Just 1 minute. Yeah, please continue. Thank you. And next one. Now let us go to the another kind of definition or classification. These are the three categories I showed you. But when we classify these AEFI, to know what could be the cause of this, the causality assessment, what is known, whether they are really related to the vaccine or not, then we have these main 5 categories. So please remember these 5 categories very well, because they are the most important one. Minor and severe and serious, easy. But here you have to be little more pay attention. The first is vaccine product related reaction. This is an AEFI that is caused or precipitated by a vaccine due to one or more of the inherent property of the vaccine product. So the vaccine is such that it will result into this kind of problem in certain number of individuals. That is the product related. Second one is vaccine quality defect related. The AEFI which is caused or precipitated by a vaccine that is due to one or more quality defects of the vaccine product, including its administration device as provided by the manufacturer. So there is a defect in the quality of the vaccine. It's not only product, but it's the quality. The third is immunization error related. This is an AEFI which is caused by inappropriate vaccine handling, prescribing, or administration. Meaning whether the vaccine is all right, but probably when we are giving it, there is some problem. So the error is because of the programmatic error here. The fourth is anxiety related reaction, where the AEFI is arising from anxiety about the immunization. This is occurs more commonly when we have these your campaign mode programs. And last is a coincidental, an AEFI which is caused by something other than the vaccine product, immunization error or immunization anxiety. None of these is there, but coincidentally at the same time whenever the vaccine is given, something more is occurring, and therefore it is a coincidental event. It has been reported as AEFI, but it's not related to the vaccine. So please remember these are the cause specific definition. Next one. These are the examples. So for example, the first one, product related, where it is because of the inherent property of the vaccine, like an extensive limb swelling following DPT vaccination. We know that DPT vaccine is more reactogenic. It can lead to swelling, pain, and then also sometimes febrile seizure. So this is vaccine product related. We know it very well. This is the number 1 category. Number 2 category is quality defect. Failure by the manufacturer, completely inactivated lot of inactivated polio vaccine, which may lead to cause paralytic polio. This has happened in the past once, what is classically known as Qatar incident, where the recipients were given a vaccine which was not completely inactivated, and therefore it has resulted into the disease rather than the protection. So this is now rare, very, very rare. Say now it is occur. Whenever we see any quality defect, every vaccine batch is being tested properly in our CDL Kasoli, and then it is only released. So therefore, quality defect is not a problem nowadays. Third is immunization error related. Transmission of infection, for example, by contaminated multi-dose vial. So this can result into infection which is being transmitted, or sometimes it can result into some kind of abscess formation. So depending upon if the installation has not been proper, so therefore it can result into abscess formation as well. So this is what is known as immunization error related. And examples of the anxiety related is vasovagal syncope in an adolescent following vaccination. This mostly occurs whenever we have these kind of campaigns. The adolescent girls mostly, whenever they are being given vaccine, maybe somebody may have that kind of fainting attack, and it resolves usually within a short period without much problem. And lastly, the coincident fever is in fact caused by malaria. So suppose a person has fever, now you test it and the malaria parasite is being, in the blood film found, then the cause of fever is malaria, not the vaccine. So it is a coincidental event for that matter. So please remember, these are the 5 and these are the examples. Next one. So product related we have seen, quality defect related we have seen, and the immunization related. These can be resulted to minor or severe reactions. All these are very well known. 1, 2, 3. Immunization related as well. Next one. Next one. Right. So immunization error-related transmission of infection by contaminated multi-dose vial. A very serious problem here is what you might have heard about toxic shock syndrome, which may occur after the MMR vaccine. So the MR vaccine or the measles vaccine, which is kept for a long time after reconstitution. So since it doesn't have any kind of preservation, so therefore it can result into transmission of infection and then ultimately what is known as toxic shock syndrome, and it can result to the death of the child also. So there have been cases which have been reported for this kind of thing. Therefore, you have to remember the exact indication of the vaccine, when it's to be given, how it's to be given, and then what are the precautions which has to be undertaken while giving the vaccine. Next. So these are the potential causes for immunization error. What we are talking about, the third one. Non-sterile injection will result into abscess formation, reconstitution error. So reconstitution has not been done with a proper diluent whenever the vaccine is being reconstituted. And this has been seen in the past with many cases where the diluent has been used, proper diluent has not been used, but something else. Even in one case, insulin was used, or even in another case, some muscle relaxant was used as a diluent, and therefore has resulted into permanent disability or death of the recipient. So therefore, please remember very well that vaccine which needs to be reconstituted, it comes with a diluent, and that diluent has to be used only for that purpose. Injection at the incorrect site. For example, in the gluteal region you are giving, which is not the proper place, and it can result in abscess formation later on again. Vaccine transported or stored incorrectly. So here, for example, when we say that cold chain has to be maintained, the cold chain has not been maintained properly, it can result into some kind of, again, adverse event. And finally, the contraindication ignored. So there is a contraindication. For example, we were talking just about that child who had suffered from leukemia or cancer, when all vaccines should be to be avoided. Say, for example, oral polio vaccine or live vaccine. So here it is contraindicated live vaccine here, but if you have given the live vaccine to this particular recipient, he or she may suffer from some kind of disease. It can result into a condition, disease, rather than preventing the disease. So therefore, please remember the contraindication have to be kept in mind whenever the vaccine is being given. So these are all immunization errors which can occur in a program or otherwise, and have to be kept in mind while vaccinating a child. Next one. These are the 5 I have told you. 1, 2, 3. The 4th is anxiety-related vasovagal syncope in an adolescent. We will see some of the examples. For example, next one. Next, these are the 4 anxiety-related reactions which commonly occur. Fainting attacks, it is relatively common, but usually affects older children and adults. It does not require any management beyond giving the injection while patients are seated to avoid injury caused by falling, and placing the patient in a recumbent position after the injection. So reassurance may be that to be kept in a recumbent position so that the blood pressure doesn't fall, and after some period of time they usually recover very well. Hyperventilation as a result of anxiety about the immunization, and it can cause high-headedness, dizziness, tingling around the mouth and in the hands. It also doesn't require much treatment. Vomiting, younger children tend to react differently with vomiting, a common anxiety symptom. Breath-holding spell may also occur, which can end in a brief period of unconsciousness. They may also scream to prevent the injection or run away. Convulsions and anxiety reaction to injection can, in rare cases, see very rare, what is known as pseudo-conversion, what we talked about, can result into conversion. These are all immunization anxiety-related reactions. Commonly, these are the 4. Next. For the coincidental, again, the example I have given, fever occurs at the time of vaccination, temporal association, but it's caused by malaria, and you isolate the malarial parasite from the blood. Next one, yeah. So coincidental events require rapid follow-up. They are inevitable when vaccinating children, especially during a mass campaign. So you have to see epidemiologically also in that area whether some kind of other problem is going on or not. So maybe dengue season, for example. The children are supposed to get even dengue fever that time, or the person. So therefore, if the person has fever, whether it is because of the vaccine or because of the dengue, we don't know. So therefore, these kind of epidemiological factors are also have to be kept in mind. Expected coincidental events can be estimated by evaluating normal incidence of disease and death at this age group, coverage and time of immunization. So you need to know background rates of some of the conditions. You need to know whether in that particular area some other kind of problem is going on or not. Immediate investigation is critical to respond to communities' concerned about the vaccine safety. It is very important because you are vaccinating a large number of population, and therefore you have to address that kind of community concern. Should not stop the vaccination, should not have any kind of knee-jerk reaction that you suspend the vaccinator or you stop the vaccination. That should not be done. It should be properly investigated to maintain a public confidence in the immunization so that your vaccination program does not suffer. Otherwise, there is a problem. Next one. Now, this is the coincidental. For example, somebody may say that death following vaccination, but you can see here that the infant mortality rate, which is currently 26 per 1,000 live births. So in a year, estimated number of infant deaths, you can see one day 1,877, and whereas number of DPT immunization is 1,95,000. So you have to see whether the death is causally related or not to the vaccine, which is unlikely. The only problem only where the death can occur where following a vaccine is anaphylaxis, if it has not been maintained or not been treated properly. Otherwise, it doesn't result. So no deaths have been till now associated with the vaccination, except the anaphylaxis. Next one. Next, yeah. Now, finally, the cluster. The cluster of events is 2 or more cases of similar adverse event related to time, place, or vaccine administered. From one place, 2 cases of similar nature, maybe in the same kind of time when the vaccine was given with the same person, same vaccinator, then it is a cluster. They can be associated with a particular provider or health facility, or vaccine which have been inappropriately prepared, which have been contaminated, or which have been inappropriately stored during the transport. So that can result into more than one person having a similar kind of problem. Say, for example, rashes, toxic shock syndrome for that matter. So adverse reactions, these kind of adverse reactions, they can result into clusters. So clusters are 2 or more cases. So more than one is become a cluster. So this is the definition of cluster, and this is again comes into serious adverse event. Next. And that was, I had one slide for management also. I can just give you one.
Just a minute, I'm sharing these slides again. It has been stopped.
Management part.
Yeah, just a minute, sir.
Or should I read out otherwise? It is not possible.
So just a minute, I'm sharing it.
Please.
We will post test link after Dr. Dubey's session, and I also have a small presentation. Please stay back. Meanwhile, sir, can you take this question? Clarify
Sure.
time relationship.
Sure.
How much is the time period?
I'll just read out this one. For management part, because this also was included. Minor adverse events usually self-limiting within a short period. For fever, pain, swelling, redness, you give paracetamol, 15 milligram per kg body weight, and maybe cold compression and reassurance. So please remember, nowadays paracetamol syrup is being given to the children. It is being dispensed. Previously tablets were being given, but now it has been replaced with paracetamol syrup. And most of the time, these minor adverse events, they do respond. So therefore, there is no problem. For severe adverse events, usually respond to the symptomatic treatment, may require observation in the emergency room for some period of time, but not hospitalized. So, for example, you may keep for some period of time the person. We always advise half an hour waiting after the vaccine has been given, but maybe longer than that. And anaphylaxis, intramuscular adrenaline. Nowadays, all ANMs are being authorized to give adrenaline. In fact, there is a anaphylaxis kit, AEFI kit, what is known as AEFI kit, which is being given, which has adrenaline in that, and immediately if you give adrenaline, they respond very well. The serious adverse events, hospitalization is there, and it has to be investigated, and treatment will depend upon the clinical diagnosis. For example, if there is an abscess formation, incision and drainage, antibiotic treatment. If there are seizures, anticonvulsants, and so on and so forth. So depending upon what kind of problem the child has, serious adverse events, they will require most of the time a little longer period of treatment, hospitalization, and investigations. So this is the management part. It's not much, because in the serious, there is a long list of conditions which can occur, various kinds of problems can occur, and therefore they need to be treated as per the condition, as per the valid diagnosis, what is known. Thank you. Now we can take the questions.
Yeah, thank you, Dr. Dubey, for sharing your experiences, the causes of AEFIs and how to handle those. I hope this has empowered our participants here, how to do it properly. Regarding this kit, AEFI kit, adrenaline, in my experience, I've seen, since these things don't happen very often, so whenever we need this, even in the crash cart, whenever we need this adrenaline, it turns out to be expired. So please kindly check this kit regularly from time to time for expiry. If it is expired and you don't have enough time to go and replace this with the indated adrenaline, so if it is with you, for anaphylaxis, it is said if you have adrenaline with you, then only you will be able to save the patient, because you just have 3 to 5 minutes with you. And if that you waste that time in locating, finding, that will waste a lot of time. Second issue that we find, with adrenaline is, you need to make a proper dilution for this adrenaline.
Yeah.
So many
Yeah,
of us.
usually that kit has the dosing schedule and dilution as well. And
Okay.
it is a ready-made kind of thing, so that you don't waste time, because this is something which is to be, treated within minutes, as you are
Yes.
saying. Absolutely right.
So, sir, this kit has the epinephrine pen or something with diluted adrenaline, or they have to make the dilution?
Diluted adrenaline, already diluted.
Okay, that's very good. But then you have to watch for the expiry date. So, because most of the time, whenever anaphylaxis or serious reaction happens, we panic around and things go wrong at that time. Okay, I think the questions earlier we had two questions. Although it wasn't combination, can you combine different vaccines? And missed doses. What do you do if the child has missed the immunization on schedule?
The first is combination vaccines are nowadays available. The pentavalent, which has got 5 components, hexavalent, which has got 6 components, trivalent, which has got 3 components. So all combination vaccines, there is no problem. So at the same time, you can give as many vaccines as you want. There is no issue. All the vaccines can be given at the same time. And the schedule is like that only if you go to the National Immunization Program schedule. For the missed doses, whatever doses the child has missed, age appropriate, at what that particular age which vaccine can be given. There is no contraindication, it can be given. So for example, let me give you one example, say DPT, for example, DTWP, whole cell pertussis vaccine, is to be given up to the age of 7 years. If the child is 8 years old and he has missed his DPT before, DTWP should not be given, DTAP should be given, which is acellular pertussis vaccine. So please keep those age at which it is to be. If there are no contraindications, whatever vaccines have been missed can be given. There is nothing like repeat. For example, suppose somebody has received 2 doses and after 4 weeks, or third dose was to be given, but 2 months have passed, 6 months have passed, there is no problem. Whatever dose you give now will be the third dose. So don't, repeat the doses. You can count the previous doses also for the primary ones or the booster one.
There's a question, if BCG is missed and child is 11 years, can it be given?
Usually in the program, we give up to 1 year, right? But now you might have heard about the adult BCG vaccination also. It is coming on. But yes, it can be given at any age. There is no issue. There is no issue. But the best advantage of the vaccine, we say that the vaccine should be given at the age when the advantage is maximum. And you see the BCG has been there to prevent either disseminated or tubercular meningitis in children. So that is the most effective part. So if you do not give in the childhood period, the advantage is lost. That is what I'm saying.
Yeah, it is best to follow the age appropriate vaccination,
Exactly.
but if somebody has missed, we can give it and do a catch up vaccination to maximize the benefit. Sir, regarding the multiple vaccine being given in one session, I think these have to be administered at different sites. Are there any guidance for that?
Yes, different sites. One is maybe that one in the upper limb, left, right upper limb, then on the say thigh can be given. And if you have to give at the same place, for example, left thigh or left for that matter, you should have at least 5 centimeters apart.
And don't combine two vaccines in one syringe.
No, don't combine. Say the combination vaccine is there, then it's fine. Otherwise, you need not combine. You give separately. Say pneumococcal has to be given separately. Pentavalent has to be given separately. If you give DPT alone, it has to be given separately. Don't combine. You should not combine. If it is a combination vaccine, fine, but otherwise you should not.
Yes, because many people think that, since combinations are available, they can also mix these vaccines.
No, that's not advisable. That's not recommended.
I think, are there any other questions? After 18 years, adult BCG vaccine is recommended. How beneficial it is?
No, not recommended yet. It is yet. Actually, the government has a program now, which is under the trial mode, the clinical trial mode. You can say government is trying to do it, and let us see if there is a benefit. There will be a recommendation. Presently, there is no such recommendation.
I think the next question is about, can 2 live vaccines be given together? I think
yes.
It has been answered. You can give as many, but at different sites. Okay.
That is injectable. Oral polio vaccine, for example, live vaccine, you can give. Rotavirus vaccine, you can give. There is no problem. They are being given at the same time.
If ARV is missed by patient and he comes late, he may be given rest doses.
What is anti-rabies vaccine?
Oh, rabies wala hai ye, okay. I think usme bhi same schedule, principle is followed.
The schedule is same, but you have missed a certain period of time. So the benefit will not be that much as you probably would have had if 0, 3, 7, 14 and 28. Even if you say 14, that doesn't matter, but 0, 3, 7 are the most important. You have to start immediately and then with the immunoglobulin also, monoclonal antibody also.
And emphasize at least 3 doses should be given.
Yes, at least
5 doses have been recommended. Ideal is 5, but minimum is 3.
Exactly. Right, absolutely right.
Sir, a question about cluster events and time relationship.
Say, as such, there is no time relationship. It depends upon how frequently it is occurring. Say, most of the time they are of the same time, most of the places. But suppose one person has got, say, giving, and then you are reporting more abscess today, for example, maybe given after 4 days, maybe given after 7 days, and the same site. If repeatedly something is coming up, then it is also a cluster. So therefore, it will depend upon the situation. Say, adverse event like TSS, same time for that matter. But if it is because of abscess or something other, because of the problem of the vaccinator, it can be over a longer period of time, but the same site. If it is same, vaccine lot, then it could be different times. Say, for example, in the past, we have seen one kind of BCG vaccine had given more of BCG lymphadenitis. Now, this vaccine was being given to a large population, but more number of lymphadenitis than the background rate or what we used to see. And over a period of time, it was over a period of 6 months or so, that again a cluster, because the same lot of the vaccine was giving rise to this kind of problem. And then it was investigated. So it depends upon time, place, person, and depending upon the investigation.
Usually when we say, temporal relationship, if you can establish, the event and the timing, if it is within reasonable time, then you say that there is a temporal relationship. This is true about the adverse drug reactions to medicines also. You should try and find out if there is any, time relationship between
Yeah, a
that.
specific
Is
pattern.
there earlier or not, and whether the severity increased after increase in the dose, like that. So those same principles apply here.
Exactly. It depends upon the condition.
Sir, there is a question about vaccine AEFI. What is the role of injection Avil and Efcorlin?
Very little. I would say the only place where it can be allergic reactions, rashes, for example, but not for anaphylaxis. Anaphylaxis, adrenaline is the drug of choice, has to be given. Other drugs, depending upon the symptomatics, allergic rash, for example, person experiences after a few hours or next day or so, there you can give other anti-allergic medications, no problem.
Efcorlin is that steroid, no?
Yeah,
Uh, Actually doesn't immediately help. So mainstay of treatment is adrenaline. So
adrenaline,
focus on the
exactly.
adrenaline.
Emphasize again and again. For anaphylaxis, give adrenaline. For severe kind of hypersensitivity reaction, give adrenaline, because that will save the life.
Efcorlin will take few hours to manifest its effect. So don't depend on Efcorlin and these things. These are additional supplementary things if required, but adrenaline is the mainstay of treatment.
Correct.
I think we are giving zero polio, HBV at birth, giving BCG at the time of discharge, say third day. Is it a right practice? Yes.
Yeah. You can give. See, ideally, we give at the birth or next day of the BCG, but you can give any time, no problem.
Reporting of AEFI, how should it happen? I think this is, I was waiting for this question to come from the.
See, during COVID time, there was a platform, what was known as COVID, where anybody could report adverse events. Presently, the system is like this, that you have to report through the medical physician or through DIO. The best person is DIO, District Immunization Officer. So that is the place where, but the government has come up with again like COVID UWIN, and shortly the facility will be there that a person can report. I mean, even an individual can report in the UWIN platform about this adverse event whenever they experience such kind of problem. So at the time, presently, for example, you have to report through the vaccinator, ANM, or to the medical officer, or through the DIO.
Sir, are there any timelines for reporting?
No. You can report even after 6 months, even after 1 year, whatever time. As I said, any time. See, but you just think that whether it is really, it could be related or not. That is the most important thing. There are few things. If BCG lymphatitis, for example, it can be even after 6 months. So you can report after 6 months, no problem. But it's not that the vaccine has been given today and say after 6 months somebody has got febrile seizure. It cannot be related. The window period, that kind of period has to be kept in mind. So please remember that. Yeah, that's the only thing. Otherwise, though, it can report anytime.
But immediate, if something has happened, it is good practice to report then and there. Otherwise,
Exactly.
people
Because more the time
forget.
passes on, the investigation will become problem. Now, say for example, COVID, people are now reporting even after so many times, such a long period. So there is no time period as such. But yes, if you have experienced some kind of adverse event and you feel this could be related or not related, but it could be even if in wellness in mind, if you have that kind of problem or presumption, report it. No problem. We will investigate and find out whether it is causally related or not.
I think you've answered all the questions.
So very nice that you.
डोज ऑफ एड्रेनलिन चाहते हैं तो वो सर गाइडलाइंस में लिखा हुआ है आई थिंक यू कैन
गाइडलाइंस में है जो AEFI के उसमें भी है एज डिपेंडेंट एंड वेट डिपेंडेंट ऑफ द चाइल्ड. So it is already given there, very ready reckoner. You need not, remember it. You have to follow that.
Thank you, sir, for sparing time for us
Thank
and
you. Very nice.
answering all the questions patiently, queries of our audience here. I think they are all thankful to you, and it would help them in their day-to-day practice in their own settings wherever they are working. Okay.
Thank you. Thanks.
Thank you, sir. Thank you, sir.
Thank you.
Thank you.
Bye.
Thank you, sir. Thank you so much.
Okay.
The last part, now I will quickly talk about the challenges related to it. Aman, okay. I think people
before
don't
we
need
start-
any introduction for me. So you can.
So before you start, ma'am, I would like to take this chance to introduce you since it's the first session of the series. So,
Okay.
ma'am is the, I would like to welcome Dr. Sangeeta Sharma, ma'am. She is the professor and head of the Department of Neuropsychopharmacology in the Institute of Human Behavior and Allied Sciences, IBHAS we call it as. She has had degrees in pharmacy and QMA, HO, and has had done MBA in healthcare administration as well. She's the honorary president of the DSPRUD, that is the Delhi Society for Promotion of Rational Use of Drug. It is an NGO in the forefront of promoting the rational use of medicine and improving the accessibility, availability of quality of drugs since the 1996. And she has conducted more than 200, I think it should be more than 300 till now, ma'am.
Yeah, you have to
Just
update this.
to build the capacity for doctors, nurses, pharmacists, and many other cadre of the public health system. She is also is a rich and diversified professional and managerial experience in the health. And one of her pioneering work is the standard treatment guidelines, which is a manual for medical therapeutics. Ma'am, over to you for your session.
Thank you, Aman, for your kind introduction. If you stop sharing, I can share my. Okay, now I can share. Can you see my? Yes, you can see my slides. Okay, I will not repeat whatever has already been covered, but my aim here was today to discuss some of the issues which are important when we are considering this immunization or dealing with vaccines. One of the very important take-home message that I want is one of there are many drivers for antimicrobial resistance. Infections remain the one of the major burden of diseases today, and it is responsible for a lot of mortality. And some people even say that we have entered into a post-antibiotic era where even the presence of so many antibiotics, we see that the patients are not recovering from infections. They need to be hospitalized, and in ICU they get get these infections, and cost of treatment is increasing. Many people die also. So AMR is a very looming another pandemic that we have here in front of us, but we are not appreciating it because this is silent one. We all appreciated, we were all worried about the COVID-19 pandemic, but the magnitude of the harm, number of deaths caused by AMR is much more than the total number of deaths caused by COVID-19 pandemic. So that's the kind of the magnitude that we have. We need to do this something very seriously to address this problem. And we know one of the there are many drivers for this AMR. These are health systems, our demographics, social systems, cultural beliefs, environment, globalization. So we are still facing this infectious disease burden. And with every time we fall sick, there is an opportunity for antibiotic prescription. But if you look at the practices being followed, many people are overusing, misusing these antibiotics for viral illness, and if or they are using it for extended period. And on the other hand, there are many people who do not even have access to simple antibiotics. So we have both kinds of paradoxes here: overuse, misuse, and underuse. So we need to really look into this problem. And we see that vaccination. So what has happened over the last 2-3 decades is, earlier we were getting new classes of antibiotics, so we were complacent that okay, doesn't matter, even if the bacteria develop resistance to the antibiotic, there will be a new class of antibiotic and we will take win over this infection. But for last 2-3 decades, we have seen that there are no new antibiotic classes coming up. What we have right now, you may be saying, there are new drugs being marketed every time, but they are not new classes. They are just the new generation of a class. For example, fluoroquinolones, we have first generation, second, third, fourth, fifth generation. Cephalosporins, we have first, second, third, fourth generation. Even nephromycin that you must have heard in the news is again one of the macrolide class antibiotic only. The only difference is that earlier perhaps these antibiotics were given parenterally, now you can give it orally, or the spectrum of action is different, targeting specific bacteria. So but the why am I telling you all this is that we cannot rely on new antibiotics, because pharmaceutical industry is not interested in developing new antibiotic, because they don't get enough return on investment. It takes billions of dollars to develop a drug and bring it to market. Time, it needs 10, 12, 15 years of time for bringing a drug to the market. So they're not interested, because within 6 months to 1 year of marketing a new drug, resistance starts reported. So eventually then patients do not respond to this. So we need to look at the alternatives to antibiotics. So one of the very good alternative to antibiotic is vaccine. You've heard both of them, Dr. Dubey and Dr. Anup Warrior. We have so many of vaccines where we can prevent these diseases. So certainly we use, because every time you get an infection, there is an opportunity for prescribing antibiotics. So if you have a vaccine, then the vaccines improve response, herd immunity is there, and it reduces the reliance on antibiotics. So, and also with vaccine, because herd immunity has developed, there is a reduction of transmission of drug resistant strains amongst others. So it overall provides a protection to us. So we must maximize the benefits of these vaccination. You have heard Dr. Anup Warrior talking about vaccines being efficacious to the extent of 94%, 95%. So we must utilize that if possible, if it is, if it weighs the benefit versus risk, cost, etc. But vaccines are a very important tools that we have. And he has already enumerated on the vaccines, pneumococcal vaccine, influenza, this Hib vaccine, HPV vaccine, meningococcal. There is enough evidence that these has saved lives, infections. So we must capitalize on this. And on this, if you look at this is the, study where they reported vaccine avertable AMR burden by infectious syndrome and pathogens. So we must maximize on these tuberculosis, 23% bloodstream infections, and here are the causative organisms which are mainly responsible. So LRI, thorax infection, and so wherever possible, if vaccine is available, we must try and avert this AMR burden by using these vaccines. So if you look at the organisms here, microorganisms here, there is a long list here, but some of these are responsible for the majority of infections. But look at the for these only 2 vaccine preventable among pathogens are available. So we need to definitely work on developing more number of newer vaccines, but whatever vaccines we have, we must utilize this. I think we have already answered this. Multiple vaccines during a visit. Follow instructions of the manufacturer. Only those which are available in ready-made combination, they should be used, but don't combine them at your end because we don't know. Then there is another situation that may happen in the clinics is vaccine leakage during administration. The child moves, or the entire dose doesn't go. So although we cannot assess accurately the amount of vaccine which the patient has received, but consider it non-standard injectable dose and repeat it if possible. For inactivated vaccines, administer the repeat dose at the earliest opportunity. Oral vaccine, when you are administering rotavirus vaccine, for example, generally administer these before the injections, because then the child becomes cranky and may cry and may not take this, may just vomit it out. So it is better to give oral vaccine before you give the injections. Then administer this liquid slowly down one side of the inside cheek towards the back of the infant's mouth. If any dose is missed, should be given at the subsequent visit when indicated and feasible. Do not re-administer a dose of rotavirus vaccine if the infant regurgitates, spits out, or vomits during or after administration. So no repeat dose to be given. I think immunization in minor illnesses is not a contraindication. So many a times these vaccines are denied or refused or deferred on pretext of fever, diarrhea, respiratory. If these are minor, still you can go ahead with vaccination, but do be mindful of special circumstances in preterm infants, very low birth weight patients, preterm. They can be given these vaccines if they are stable otherwise, and a chronological age as per according to the chronological age, irrespective of the birth weight or period of gestation. Then those who are on steroids, there are guidelines for this. I'll not go into this. This is prednisolone. If they are getting this for more than 14 days, then live vaccines will be less effective. So give it after 1 month. And Dr. Anup also mentioned, for example, immunosuppressant patient is on immunosuppressant. So by 6 months, you have to look at these guidelines and then give with the vaccination. So killed vaccines are safe in patients on corticosteroid, but they may not be completely effective in such situations. Avoid live vaccinations. OPV should not be given to the household contacts of children on chemotherapy during routine. Then there are special situation, could be asplenia, or patient is to undergo splenectomy, or sickle cell anemia patients. This is very common in some of the states in India. So you need to know what vaccines can be given and what cannot be given in this special group. If it is a elective splenectomy, initiate vaccination with these 2 weeks prior to splenectomy. In emergency splenectomy, vaccinate 2 weeks after the splenectomy is done. So pneumococcal, Hib, typhoid, meningo, they should be given in addition to the routine vaccination in these patients. then there are detailed guidelines by NACO on HIV infections, those children suffering from HIV infections. Again, the same principles apply here. Then pregnancy is one major special group where we need to be considerate. I think Dr. Anup Warrier has shown all those vaccines recommended in pregnancy. This is from CDC, more or less the same routine vaccination and not so routine vaccination. But the take-home message here is that you avoid live attenuated vaccines in pregnancy. That means measles, MMR, varicella, yellow fever, and oral polio vaccine should be avoided in pregnancy. Live vaccines, they can potentially cross the placenta and infect the fetus, posing a risk for congenital infections. Then HPV, usually, again, this is not recommended during pregnancy. If inadvertently it was administered and you discover pregnancy later, don't proceed with the next dose, postpone next doses. Although there is no harm has been documented, but still there is not enough safety data which is available. So approach is more or less is of a precautionary measure that you try to minimize the risk. So there is a theoretical risk. This is a non-live recombinant vaccine. Vaccine is a virus-like particles. It is a theoretical risk, not documented, but it is good to be, cautious at this time. And also there is a lack of necessity because the role of this HPV vaccine is preventive only, and so it needs. Vaccine is needed only for those who have not yet been exposed to HPV infection. And HPV infection in pregnancy is also not very high. So you can, that is why HPV vaccine is not recommended in pregnancy. So focus should be more on the screening part with pap smear and HPV testing, and focus more on the preconception vaccination of adolescents and young adults before they become sexually active. So timings of these vaccines are also decided so that they have optimal efficacy. For example, Tdap, when the maximum benefit is being passed to the fetus, that happens at 27 to 36 weeks. That is how the timing have been decided. So if, as I said, if live vaccine is inadvertently, administered to a pregnant woman, confirm pregnancy and defer the vaccination series. And you have special groups. I think Dr. Warrier has already explained it very well. Now, there are three issues that we need to be very careful. Cold chain has to be maintained, use of diluents and Lassa vaccine. Somebody asked this question also. The problem, the extent of the problem, that if these vaccines are not stored at the appropriate temperature as recommended, it can lose its potency. So we will be under the false security that we have taken this vaccine, but if it has been exposed to either heat or cold, it may lose its potency. So maintenance of cold chain is very, very important. And one thing that you must remember, I am not going to read out the entire slide here, but the take-home message that I want here is that remember, one temperature does not fit all. It does not mean that all vaccines need to be stored at 228 only, or all vaccines can be put into the freezer. There are certain vaccines which can be both heat and cold sensitive. There are certain vaccines which are heat sensitive, and while there are other vaccines which are cold sensitive. So please remember, manufacturers usually provide the temperature storage that needs to be maintained for this. MMR, this should be frozen at -15. So MMR vaccine can be refrigerated or frozen. So remember that you must consult the manufacturer's temperature. Now, there is another myth that colder means better. That is also not true. Colder is not always better. Major culprit here is some of it. We think if we put it into the freezer, then it would be better. As I told you, some are sensitive to cold as well, so you need to store these vaccines at the right temperature. And whenever you are storing these vaccines in the whichever type of refrigerator that you have, it should not touch the coolant. It should be away from the vent, because the temperature even within the refrigerator may vary in different sections or shelves and doors of these refrigerator. Then there is a very important, somebody asked this question about look-alike, sound-alike vaccines. We are all aware of the look-alike, sound-alike medicines, but these Lassa pairs are also seen in vaccines. Many of the adult and pediatric vaccines are same, packaging are same, but the dosage may be different. So you really have to identify this very clearly. And sound like is TD, TD, TT. All of these sound similar. So and also some of this may be having similar packaging. So some of them come with the diluent. Some of the diluents, both vaccine and the diluent needs a cold storage. But for some, diluent can be kept outside. So you need to really be careful about this. What all can be kept together in a refrigerator or what. Then there are many sound-alike names, DTaP, Tdap, Hib and hepatitis B. Many people mix up this. Hib is H influenza. Hepatitis B is hepatitis. Hep B is hepatitis. So, but many people think that they are same. So be careful about these Lassa pairs and diluent. Please use the specified diluent which comes with the vaccine only. Don't mix it. If any other can be used, just again then read the package insert. Third thing, important thing with vaccine is that you need to look at the expiry dates. You should use them within the expiry period defined, and we must be able to read the expiry dates properly, because if a specific date is given, if it says 16th August 2015, that means you can use it through up to this period. But if there is no date specified, that means end of the month you can use this drug. Then common site, where do you administer? This is also many of these abscesses or reactions, as Dr. Dubey was saying, happen because of the wrong site errors. You should always use safe injection practices, 1 needle, 1 syringe, 1 patient. Do not leave any needle in the septum. Whenever you are opening a vaccine vial, decontaminate, disinfect the septum of the vial, because this is where when you are piercing the vial, you are bringing this contamination into the vial. And leaving a needle, a syringe in the septum is again a cause of concern because of this contamination. Now, when you reconstitute, for how long can you use this vaccine after reconstitution? For this, you must follow beyond use date. You must write down when it was opened and what is the beyond use date, that you cannot use this, some of them after 6 hours may not be usable, some may be usable for more time. So again, go by the manufacturer's guidelines on this and write this date on the vial itself, so that excessive, you don't lead to this. Then of course the injection safety issues, these are very important, because local abscess formation and these are very common. So reconstitution has to be done properly, use the proper diluent, and immediately before immunization reconstitute, there is no need to wait for the vaccine to reach a room temperature before giving. Maximum 30 minutes, within 30 minutes you should be able to. And if you must always visually inspect the vaccine vial for any particulate matter, discoloration, Sometimes this may not be visible to naked eyes, but if there is discoloration, and if you look at the VVM monitor, label, accordingly, you have to use this. Record keeping documentation is very important. When was given a date, route, site, all these things. Then unused, disposal of unused vaccine is another important concern. Segregate them as pharmaceutical waste in yellow bag with clear biohazard label, secure packaging in a leak-proof container, double-layered packaging, and then into a waste bag, yellow bag here. Maintain storage condition until it is disposed of. Waste logbook and compliance records are equally important for unused vaccine. You cannot dispose them off in the regular trash or flushing down the sink or a bathroom. Refrain from on-site incineration. Do not mix with other waste, and never delay their disposal, and avoid keeping indefinitely. Then I think other things, vaccine hesitancy, skepticism, campaigns, we have already talked about it. There are many, myths and misinformations, like for polio. Each one negative report about vaccination can alter the thinking perception of public. So one, be very careful about these things in public domain. There was a report of MMR vaccine with autism, and it declined the vaccination, and then later on you see that there is a surge or there is an outbreak. So similarly, there were a lot of controversies, myths about HPV and sexual activity, flu vaccine in pregnancy. Many people think that this can affect the fetus badly, or it will affect their fertility. So this all can be taken care by public health messages. Language and literacy barriers should be identified. Many people don't understand. I understand this, but the local language, they may have a different connotation to it. So you must understand these literacy barriers and language barriers. And of course, we need to build trust here within the health system. Then regarding specifically about the adult vaccine, we don't have comprehensive data. We don't know how much the adult vaccination rates are, what is the coverage, and what is the outcome. We don't have a good surveillance system. So we need to build that and track the vaccine preventable diseases, whether they are responding effectively or not. I think this is one shot, what should be given to all, which vaccines are for over 60 and situational like that. So we have a lot of resources now available. We have a purple book from Indian Academy of Pediatrics for immunization in children. Then Dr. Dubey was talking about this AEFI, adverse event following immunization. These are the operational guidelines. These are very good guidelines. You can refer to these guidelines for reporting. And Dr. Anup Warrier was also talking about the consensus guidance amongst various associations in India. This is a very recent publication. You can just take a picture of this and download it. It's freely available. All these documents are freely available. Then we also have our own standard treatment guidelines, and we've been covering this immunization part regularly right from its first edition. And even with respective diseases, we have been covering these which vaccinations should be given under patient education section. So maybe you can use any of these resources to update yourself. I think with this, I will stop. If there are any questions, I'll be happy to take. Dr. Aman, can you put the link in the chat box for the post test? I hope, although I think we have overshot by some time.
Has already been posted in the chat box.
Okay, sure. Thank you. You can open this, link and start attempting it. You can complete it even after the session is closed. Okay, I'd like to thank all of you for staying back with us. Merry Christmas to you and Happy New Year to all of you. We will meet next on January 18th. Third day of the Saturday is a fixed day, 3 to 5 p.m. But usually we go up to 5:30 or so because there is so much of question and answers going on. So that, and I don't want to come in between you and the experts, because these are really very important gaps or queries that we must answer. Open vial policy, I think somebody has written. There are two shelf lives. One is unopened vial. The expiry date is written on that, so you can use that up to that. But then most of these vials need reconstitution. So once you reconstitute it, it has a new shelf life. So this new shelf life, for example, for antibiotic, some may be usable, they will have their potency, can be used within 1 day, some can be used up to 28 days. So it is defined by the manufacturer, and they decide based on the preservative used in that. So usually when you say that you cannot use this vial beyond a day, that means it does not have any preservative. So if there are no preservatives, you can use you have to use this within 1 day. But if there are preservatives, you can use it up to 28. So same thing, same principle applies for vaccines. You have to look at the the reconstitution policy, for how long can you use, because generally when you take out these vaccines for field immunization, it is said that you have to finish that within that day only. You cannot use them again. So follow those. There are Government of India guidelines for that. So follow those. There is how to disinfect the septum of vaccine? The very good question. You can use alcohol swab. 60. It must be at least 60% alcohol. Then wipe the septum of the vial. Allow it to dry. And that is true for disinfection of the skin also. Very often we do is that we apply a swab and immediately we put in a needle there, allow it to dry. It takes 10 to 12 seconds to dry, because you have to allow that time for action for this alcohol. While it is still wet, and if you pierce the needle, it does not offer the protection. Okay, I think answered. So for Lassa vaccine, like you use auxiliary labeling for Lassa medicine, so you have to also follow these labeling for Lassa. And also it is a good practice to label, the boxes where you are storing that adult and don't mix up adult and pediatric vaccine. Preferably don't put them in one refrigerator. If you are short of refrigerator, you can put them in one, but then allocate different shelves and demarcate, write very clearly, label this shelf that this is adult and this is a pediatric one. And then in addition, you can use the auxiliary label. And last point is, before you administer, you must get into this habit of reading the label again, because this can sort out many of these problems. I think you have all got this post-test link. How many times can we pierce this septum? A very tricky question. Preferably, again, don't leave the needle in the septum, that is very sure. Number of times, the more you puncture, more are the chances of contamination. So try to keep it minimum as far as possible, but I will look around. Is there any number being, designated for this puncturing? Because many of these things are not readily, explanations are not readily available. It is only by practice or by experience that you learn answer to some of these questions. Biomedical waste management, segregation of, vaccine and antibiotics, they need to be disposed of very carefully. You cannot flush them into, your bathroom or your sink, because they will affect the aquatic life. Vaccines are also, some of them, if they are live attenuated, they are having live virus or bacteria particles there. So you should not flush them. So one thing is very clear. Second, that you cannot also mix this with the other waste. These needs to be segregated separately. As I said, this will go into the yellow bag, but the bag, which you use for this yellow bag it should be leak proof, double layered, because if they leak out from this can contaminate the other. So it should be double layered. And biohazard label, this is a mandatory requirement for all the biomedical waste under this amendments. But this is you have to be really very particular about this when you are disposing of vials. So, and again, don't try to open these vials at your health facility. You don't need to do sterilization or autoclave at the health facility level. Just put it into this and give it to a authorized medical waste, whosoever agency has been authorized. Even if it is not allowed, incinerators are not allowed, but you don't have to do incinerate at your health facility. You give it to the authorized agency to do this. You will get the certificates. The NHSRC people will go through the pre and post test, match whoever taken pre and post test, and then find out and prepare your certificates. You will get these by your email with which you have registered. So don't worry, but it may take 7 to 10 days or maybe more. Don't worry, you will get it. Second is, for the last 2 series, we have been able to provide the YouTube link to this. Those of you who could not, attend the entire session, had some, we know that you are also, required at your hospital, so you may not be able to attend the entire session. So you can access that. We will again share that YouTube link with you. Again, this takes little time. They are busy with other things. So don't bother about this. You will get it. There is a YouTube channel of NHSRC Quality and Patient Safety Division. You can access the previous sessions on that link. Perhaps, Aman, if you have that ready,
Yes,
previous
has
YouTube links, you can put this in the chat box here. Those of, 2 series means we have had 24 sessions earlier. So
it's
those,
already been shared in the chat box, ma'am. I'm sharing it again.
maybe they
And
haven't, some of them may not have.
I'm just sharing it again. And
Yeah.
also, it was on the flyer for the series. There is a QR code on the flyer, by scanning which they can go to the NHSRC website and
Okay.
see previous sessions of the series.
Very good. Dr. Satish Kumar, Dr. Satish Kanva, we must congratulate him. He has attempted the posters and got all answers correct. Good. So we have passed, your Dr. Warrior, Dr. Dubey, and myself have passed. And, the back end support, Dr. Aman has been working for quite some time to bring this session to you. And Dr. Chinmay, thank you very much to you for, taking up this, starting the 3rd series. It means a lot of things to people working in the peripheries, and this is, I'm amazed at technology's benefits. We couldn't have thought of having more than 250 people in the session otherwise, but technology online helps us to get connected from all over India. So stay connected. See you next time.
Thank you so much, ma'am. Thank you so much. Thank you so much to all the eminent speakers and especially to Sangeeta ma'am. And as ma'am has already said, this series is going to be continued for the next 1 year, and especially on the third Saturday of every month. And this time also, those participants who are is going to join all our series, all this throughout the year. They said also we are going to issue them a certificate of participation, appreciation. So thank you so
One
much.
more
And this
thing,
is,
Chinmay, just reminded me, we've been taking feedback from the participants, general feedback, not about the topic. Do you have that ready, or maybe you can use the previous form for that? Maybe we can send to your email. Please provide us the feedback also. That helps us in designing the sessions accordingly. Okay?
okay, we'll share.
We'll share in the email to the participants.
Yeah, we had been taking this feedback separately from pre-post test. Okay, over to you. Merry Christmas to all of you.
Merry
Happy New
Christmas and Happy
Year.
New Year.
Yeah, bye.
Thank you so much, ma'am. And same to you, ma'am. Merry Christmas and Happy New Year to you and all the participants. I would also like to extend the thanks to the participants for very patiently listening to the eminent speakers and us. Thank you so much, everybody.
Thank you.